Firstly, I wanted to acknowledge the Ghana people and that we work on and we live here and study on in the unceded lands. This is from NALHN's Digital Health Roadmap. So NALHN is quite, it's like the kind of smaller sibling of the three major networks in Adelaide, if you're not so familiar. And in NALHN, there's a different kind of culture. I got into this coding stuff because I walked into my divisional director's office. You just do that in NALHN, they don't really care. And you just walk in and I said, "Oh, hey Tony, have you got a minute?" He said, "Sure. What's in your mind?" I said, "Have we got a strategy for like clinical coding and documentation?" He goes, "Oh, no one's ever asked me that before." "Not really, we've done a few things. What do you have in mind?" And I was like, what if we did a fortnightly video and posters and kind of an education campaign over the 3 months for doctors from intern all the way up to consultant, and I reckon we could really improve our coding and documentation through that means. And he goes, "That's great. What do you need to make that happen?" I was like, "I need to meet the coders, learn stuff from them, and then have your support to present all this regularly." And he's like, "That sounds great. I'll email them right now." And that was it, project approved. Nothing on paper. We then saved that department $1 million over the next year, and they've incorporated documentation coding into what they do, and I've kind of built this little sub-career on coding thanks to that conversation with Tony Weiss, the nephrologist, who was there. So that's just an idea of the NALHN culture. They're actually surprisingly ambitious, and they're particularly ambitious in their digital health side of things. So they've got some really cool ideas, and really what I'm going to talk about is a few very practical ideas that either are happening now or are going to be happening in the near future, and one that's not happening now, but it's just so exciting. I'll tell you about it. So we want to really be a fully digital health service, and we want to be the employer of choice within Australia, ideally, not just South Australia, but we would be competitive, that people would come to NALHN because we're at the forefront of digital health application, not just trialling in small bits, but it's what we're doing on a daily basis. It's ambitious, but I think we've actually got the right people and the right leadership to eventually get there. Here are some things that we're doing already. So before Sunrise came along, we already had this program that we were already using in the community with palliative care and geriatrics called NALHN Viva, that works in some ways better than EMR in some areas. It's really community-minded. In some ways not as interface, but that was already there in advance. We have a cool thing with EMR with our workstations on wheels or WOWs called tap on, tap off. So I just literally get my badge and I just tap on and it logs in and logs into EMR immediately, and so there's less delays there. And then when I'm done, I just tap it and put the WOW away and walk away, and it logs out of everything very securely. So like simple technology, but something that we're using literally every day on the wards now that is again saving junior and senior doctors those little bits of time. We've got a few things like this digital twin. So the digital twin, which I'm not as involved in, but I've got a couple of digital colleagues that just get like really excited about this digital twin. They're basically constructing a whole digital model of the whole hospital and systems in this digital space so that we can then test things. Let's say, what if we had a bad day in ED and we were flooded with 100% more patients than were expected? What would that look like? How can we predict where would the key points of stress be on the system? And as an emergency response team, what would they need to do to address that on that day? So we don't have to wait for that to happen. We can literally use the digital twin to model these kind of stresses. And what if we invested extra time or funding into this bit or this bit? How does that affect the whole system, not just that little bit? So that's a really cool idea that we're already using at the moment, and we plan to kind of expand and use that to help model and predict and use our resources to the best and most efficient things. We also do, I'm really big on videos. I make a lot of videos, and that was partly where I hired. So I'm actually doing a project that's going to be finished in the next 2 weeks. I've set a very ambitious deadline, but I'm going to do it. And every single intern rotation will have a video-based orientation. I've already done about 40% of them, and I'll just give you a little kind of preview of what that would look like. Free background music. Yeah.
Hi, my name's Ben Finlay, and I'm the Chief Surgeon in the Division of Specialties.
So I've actually got divisional directors or the chief residents to give introductions and warmly welcome the junior doctors. So this is Ben Finlay, who was recently awarded as a big influencer in South Australia. So he's welcoming the surgical interns. And there's me when I talk about just talking through things like the key locations or the team structure, who you escalate to, what are your specific responsibilities, where do your timesheets go, what if you're sick, what if you take leave, how do you get a reliever, what's the policy for overtime, all these things we cover. And at the end, you then get a physical walkthrough. So if it's your first time at the Lyw McEwen or Modbury, or we've already done it for all our rural sites, you can see exactly where the theatre office is. So when you're like, the registrar's like, I'm in the theatre office, you know, because you've seen the video before you even started. And this is how you get to theatre. This is Nietzsche, one of our current interns. And this is how you get to the ortho ward. So we're doing that for every single intern rotation. And the great thing is, it's not just for you doing the rotation. It's like, if you're relieving, you can watch this video. They're all just about 5 to 7 minutes long. And you can get an idea to be able to hit the ground running, sets you up for success as a junior doctor here. And the next year, we're going to do it for all our resident rotations as well. That's one example of video, which I think is a really powerful medium that we're currently underutilising in the public health space. The other one, which I'll show you, is that we are moving towards doing better quality training for our supervisors and educators. So we're actually going to be doing a hybrid video preparation and then simulation for supervisors of how to be the best supervisor they can be. We literally did it here in the Sim Centre earlier with some senior trainees. It was a really great experience, and we went through a lot of different scenarios that all had a video introduction, and then you would do the scenario and then debrief with your colleagues. Again, I'm not sure why this is not working like that. It looked good for a second. Okay, here it is. As again, me talking with a different shirt this time, and then it's even got, I've got some B-roll footage. Hey, look, it's like hospital stuff. Yeah, more hospital stuff. That looks like a ward round. They're actually talking about their lunch. That looks like a clinic. She's telling me about her holiday, etc. like that. This is the kind of training videos that direct. Talking about, this is actually the 2-year framework, so the AHMS 2-year framework is rolling out starting next year for interns. It's not a 2-year internship, I hasten to add, and we're actually, this is training with their new entrustable professional activities stuff, assessments. Anyway, I'll go back to this one. Another idea, which is pretty cool that our digital executive director is doing, is this idea of a paperless ward. Well, sounds pretty cool, right? It's actually, surprisingly, even though we're on EMR, there's still a lot of paper on the ward. And there's still a lot of things that we do. So one of the things that we're going to be doing, and we're just going through the final approval process before we actually do this in the 1E ward, which is neurology and one of the general medicine teams. So there'll be these wireless patient monitoring systems. So rather than having, if you've been on the wards, they get like these little trolleys with like a blood pressure cuff and stuff, and it's digital, so it's all digital cool. This one would be that you actually set it up that the patient is wearing, and they can check out their own vitals anytime, and these little monitoring things. So there's like continuous saturations, continuous heart rate. They can do a basic ECG, so you don't have to always be like, oh, I have to move them for telemetry. You can have a basic telemetry in every ward. And they wear this all the time except when they're showering, obviously, which would enable us a much higher degree of monitoring of our patients. Because at the moment, most people get their odds taken every 4 to 6 hours. What if we just had everyone on continuous monitoring? The data, like I'm sure like Josh and his guys would just be like weeping over the data that we had from that and the things that we would understand about like asymptomatic hypertension and how you don't need to worry so much about it, things like that. So that's going to be pretty cool, and that will free up nurses to do more clinical care instead of recording stuff, which is what a lot of their time is taken up, documenting and recording stuff, instead of spending that time, the quality time with the patient and providing that care. Another one is closed loop medication administration. So this is the idea that you would have like a box of, let's just say that this is a medication, and let's say Mel's my patient, and so I actually go and I scan my ID that registers I'm administering, and then I scan Mel's bracelet that has her ID, and then I scan the medication and I give it to her, and the system registers it. At the moment, you get them all ready and you sign them off on the computer, and then you come and bring them, and the patient like throws them on the floor, and then like, how do you record that then? So having this, at the moment there can be more errors, even with an electronic system that does reduce errors a lot, but the more that we can have these closed loop technology, the better that we're going to get with saving time and reducing the number of errors that can occur. Another thing is CDI Engage. This is a technology by 3M that is we technically already own, but we're just in the negotiation period to have another contract with 3M. And this software would actually be that whilst our junior doctors are typing, little prompts would pop up and to improve their documentation. And they'd appear on the side and be like, I noticed that you said Lurty. did you mean community-acquired pneumonia? And you can just be like, yes, and it goes, bing, community-acquired pneumonia. And other prompts like that would improve the quality of our documentation, the safety and the coding potential there, without having all these coding queries coming back. So it's like real-time suggestion on how to improve the quality. That technology is already literally purchased by SA Health. We just need to use it properly. This is just a 3M kind of blowing their own trumpet about this. So in America, all doctors are physicians. In Australia, they're just internal medicine. So this is the idea that these in-workflow nudges powered by advanced AI, I think it's probably just normal AI, but that's okay. And they have these proactive clinical insights, and it really can learn, as a lot of machine learning things can do, and tailor it to the individual user. I think that's very exciting, and it will reduce the time that you're taking, because you're not going to go back and amend things. It's going to get it right the first time. In NALHN, we are just getting ethics approval to do artificial intelligently written discharge summaries. Not just that they're written, they're then checked by a junior doctor still, but they can actually be tailored, and you can produce multiple discharge summaries depending on the recipient. So you can have a patient-friendly one, a GP-friendly one that's not too wordy with all the stuff they actually want to know, and you can have one that's like for community mental health for your psych patient, where they want to have copious amounts of all the interviews done as an inpatient that Mel or I would never want to read through. And then you could have one for their private cardiologist as well, because you tinkered with their heart medications. You can literally just click who you want them to send it to, and they'll have these pro formas, and they'll adjust the content tailored to the recipient. All of that is stuff that at the moment junior doctors, and even I do, we handwrite these all, which is much better than, we hand type them, which is much better than the Oasis version previously, but it's still something that we could save that time. And then again, that junior doctor is spending more time on clinical care and less on documentation. And this is likely to improve things. This one is called Liew Health. They're an Australian group. We're not going to use this in, do you use this?
No, I think there's a similar product for high.
Yeah.
The high scribe for general practice.
Very cool. So we're not going to use this in public yet, or at least in the foreseeable future. I was at the Prevocational Conference, which is a conference that is for junior doctors and people who educate junior doctors in Perth. And we had this really great GP, his name escapes me right now, but does a lot of digital health stuff and has worked with really big companies. And she said, I've used 3 AI-based, this is kind of taking dictation to the next level, like where you don't dictate, it just listens to your consultation and then writes you a letter. So she said she's listened to 3 of these, or used 3 of these, and she's signed up to Liew Health. So what this looks like is that you kind of are there, you have a microphone, you take the consent of the patient, so this is going to listen to our conversation and document it for me. It's all very secure, you're okay with that? Yes. And then it listens, and then you just can focus. You've been with a GP where they kind of constantly like going back and forth to the computer, and we do that in specialist lane as well. Instead, they just look at you and just kind of talk with it, and then they examine you, and they talk out loud with the examination findings, and they say, cool, that sounds great. And then the patient might say, oh, can I have a letter? And they say, sure. You turn to your computer, and you press patient letter, and then you click print. The letter's all there. It's done. It's instantaneous. It's already produced a letter. Then they leave, and you go, oh, I need to write a referral. So you click referral, and they would say, who do you want it to? And then you press patient letter, and then you click print. The letter's all there. It's done. It's instantaneous. It's already produced a letter. Then they leave, and you go, oh, I need to write a referral. So you click referral, and they would say, who do you want it to? And it will just extract the information relevant to that specialist and produce a referral letter. Click print, done. In fact, you wouldn't click print, just electronically send it. Yes. Through health to public health, not the private specialist. So this is very exciting. I plan to use this in February when I start in private practice, and this is going to save me tons of time. And do you know how much it costs? $7 a day. That time not spent on those letters is worth me hundreds of dollars. $7 a day seems like a pretty good bargain to me. So I'm quite excited about that. Here's a referral. It's here that they've just done by clicking the referral button. So as we're doing more of this, just to conclude, the vision is, in this age where we need more and more junior doctors in the hospitals, we need more and more doctors in the community, and there's an increasing demand, but there's actually a smaller number because the medical schools are not growing, but the hospitals are, and the community is. And more people are wanting to work part-time. Good on you if you are. It's a staffing issue for me, but that's okay. It's my problem to solve, not yours. And more people are looking to take alternative pathways with their medical career. And I say good on you for that as well. That is also creating a problem for my workforce side of things in hospital. Within all of that context, we then need to make sure that the doctors that we do have are being used to their maximum potential and are being supported to have a really good experience. And I think technology is one of the main answers for that, where we can, and Josh would totally agree with this, augment the things that we're doing, even from the most junior level of the intern up to a consultant, to save time to do the things that we're actually really good at as clinicians, as humans, and take away the things that are just taking up time that a computer can do better and will always do better, and will just do better and better as time goes on. That's the vision, and that's one of the visions that we have in NALHN, and we're gradually moving along that pathway. Thanks for listening. Any questions?
Yeah, I have one. Are all these tools already available and be used? Like they are ready for use?
All of these tools are available for purchase. Some of these tools we're using in NALHN now, some of them we're about to use in the next year. And some of them, like Liew, they have no plans to purchase it, but I have plans to purchase it.
So excellent presentation. It's very exciting to see everything that can be used using technology to achieve something like this. So 2 questions. Where is the money coming from to implement something like this? And what is the evaluation process to see if it's actually bringing a health cost reduction or something like that to show to the hospital, to the local health network?
Yeah, I really believe, in the more I've been through as a junior doctor now as a consultant, that you need to invest a little bit if you want to save a lot. So there's a big focus on being like, you need to save money, we don't have enough. One of the things that is the way that hospitals get money, and this is why I got interested in coding, is through clinical coding. So at the moment, because we don't document very well in all hospitals around the world, here in South Australia, let's just take the Lyw, we don't document super well, which means the coding is not completely accurate, which means we're being underfunded for the work that we're doing. So we could be providing, and I believe that in most cases we are providing very good high quality care, as good as many other places you could go to. Statistically, it doesn't look like that because the documentation and the coding doesn't support it, and we are then being under reimbursed. So I might, for a patient, we invest in her recovery. Let's say Betty has come in with pneumonia or delirium and stuff. She stays for 7 days and again goes to rehab. Now, I might have expended $10,000 in her recovery and had good staff, good equipment, etc. She's really received good quality care and left on time. But I might only get $3,000 back from the government for her care. We're running it in a financially unsustainable way. So one of the answers is technology like CDI Engage and our documentation AI-based tools that will help fix the documentation problem, so our income will actually, for the hospital, will increase to match what we're actually doing. We're spending the money, we're just not always getting it back and recouping it. That's one thing. The other side is going, for every junior doctor that we have, we want to maximise the work that they can do. Not just junior, every doctor we have, every clinician that we have. We are spending a lot of money on trying to retain them, and then they move on and we have to hire someone new. Every time you hire someone new, you're losing money because they lose corporate knowledge. You're having to train them up, the more junior. The more that we can retain people through having really good working conditions, that's number one. People need to feel respected, they need to feel valued, they need to feel part of a team. We need to meet their individual needs for their career in our hospital networks and not treat them like it's such a privilege to work for our hospital network. I won't say what networks treat people like that, but you can just take a wild guess about that. And so even with that, in NALHN, we have an ambition, like my executive director has said this, he said, I want to increase the number of medical student and other student placements triple in the next 5 years, and I want every student who comes to NALHN to have such a great quality experience to learn and feel supported and coached and feel part of the team that they would only see NALHN as the place that they want to work when they finish because they had such a good experience and felt so valued and respected as a student. That's ambitious. I love it. I've never heard a senior doctor talk about students like that. Often students are just kind of like the flies on the walls. How lucky you are to be the fly on this hallowed wall of X hospital, literally there. And so that's another part of it, is making people feel valued. And then for each person that's there, can we invest in technology that's going to save them time and improve their work output so it's more efficient? And it's about cost modelling for that. And honestly, sometimes it's actually saying this is going to cost more, but the quality and the output will increase accordingly. So in the long term, we will have to hire less people. And if we can accept that now, our costs will be lower in the future. And you need leadership that's willing to take those risks and not just go, oh, this is a saving tomorrow of this money. This is a saving that's going to happen in 5 years. That's the kind of leadership we need. Great question, though. Yeah.
First of all, thank you again. That's fantastic, and it's very exciting to see how artificial intelligence is going to play a massive role in all of our careers and actually help a lot with letting us actually see the patients rather than all the typing and stuff. Do you have an idea about the time frame for getting some of these AI tools fully implemented in NALHN so that it's just a regular, normal thing that people use?
Good question.
Sorry if I missed it.
No, that's we could just do a quick walk through that. I mean, these things are happening right now. These things are going to happen in 2 weeks for interns and 6 months for residents. That's happening in the next 6 months. I've already got the first part of that happening. The paperless ward will start on one ward in the next 2 to 3 months, hopefully. Still waiting some digital health stuff to happen. To be honest, one of the biggest challenges is kind of like with the e-referral is that sometimes the state is trying to do things and smaller players are not playing very well. And sometimes smaller players like NALHN are trying to do some really ambitious things, and the SA-wide digital health is not as supportive or engaging because it's not as important to them. And we're trying to progress this and be like, this is exciting, this is really great, we need your help with this. And they're like, we're a bit busy with our own priorities, which is fair. So there's sometimes those are the challenges that we're working. So that's going to happen on the neurology ward soon. I don't know, this is a bigger cost investment, like the physically buying these things. A lot of these, the patient wearable things, some of them are like consumables as well. So you need to buy it. There's some that you can literally put it on their chest for that one patient and you throw it away after they've been in there. So that's obviously increased cost, but you're saving the nursing time. In the long term, that might mean you can change the number of staffing numbers for nurses to save money to offset that. I don't know. So I don't know how soon that will be. The closed loop medication probably next year. CDI Engage, like I said, we've already had access to that. It's about just using it more. This we're about to do as a trial. If that were to go well, 1 to 2 years, hopefully. This one's available. I don't think SA Health has any plans to buy it. It should. It's pretty cool. Yeah. Because it's a fair thing. Like we hear about all these cool things. And it's like, but when is that actually going to be mainstream? That's the thing. So a lot of these are on the way towards that. But not all of them we have complete control over when we can use them.
And what's been done in NALHN so that in the more distant future after this, new technologies that pop up or new AI tools or things, how do you plan to receive and integrate those in the more distant future?
Yeah, so one of the big things that NALHN does more, like other network students, but we do it a lot, is that we have a lot of key relationships with industry partners. And so they will say things like, we have this product that we want to get onto the Australian market. No one's using it at the moment. And we'll say, that's cool. Can we do a trial in our network and we'll pay you 40% of the actual cost, but we'll really involve you, and this will become like your site that you can say, look, the Lyell McEwen's using it, it's really successful, and we'll help with the evaluation and everything. Those industry partnerships mean that we have early access to these technologies, some of which we will choose to keep and pay a bit more for ongoing, and we're already familiar with it, so that's great. Others will go, this was a good learning experience for us, but it's probably not the right fit long term, so still a good experience, but you can take the technology back to sell to other hospitals now. So I think there'll be other things, but that's one of the main ones that I've been surprised at how often the people that I'm working with are thinking, even for the things that we create in-house, that they go, could we commercialise this as an extra income stream for NALHN so that we can afford these other cool things? So there's that kind of thinking that goes on a lot, where if we've got a good idea and we can sell on to other people at a reasonable price, then we're actually being quite entrepreneurial within the hospital network as well.
And for people who want to do research and innovation in NALHN, what's the current setup and how do they get involved with that sort of thing currently? What's the current
I mean, we have a lot of projects, and so it's just really people who are interested. So we have a lot of junior doctors and a handful of students who have kind of put up their hand and said, either I've got this idea, can you help me make it a reality? Or I'm just interested, are there projects I can be involved in? And we try and plug people into different projects at different points. And then I think we're hiring, are we hiring you, Stephen? We're hiring Stephen from February.
Artificial intelligence is being implemented in NALHN.
Yeah. We're big, in NALHN, we're really big on finding, we're not just trying to fill a role or put a bum on a seat, we're trying to find the right people that are going to help progress our network forward. And so I had a job interview and I went through the right process for my job, but before the job existed, I had dinner with a couple of guys from NALHN and they said, what are you interested in? And we talked about things and then they said, okay, this is cool. And then later I said, what am I going to be doing this role? And my boss said, that's not very important. It's more important that we have you and you have the skill set and the attitude that is going to take our network forward. I'm building a team of people that are going to progress the network. Again, I've never worked in a hospital that has that kind of mindset towards with leadership and with people. I've often had it just like, we just need to fill that registrar position. We just need another consultant in that area, rather than thinking kind of strategically and innovatively about how we use the people that we've got. And we are looking more and more at having roles where there's time for clinical and then there's protected time for research and quality improvement work, not just done on top of your slightly more than full-time clinical role, which is currently kind of the status quo. And certainly so much of the stuff that I've done in terms of my YouTube stuff and the coding and the discharge summary stuff, most of that I've done between 11 p.m. and 1 a.m. Until this year, where I was hired to do that stuff in working hours. And so it's nice being on a consultant contract, and I now get paid a lot more to do less work in total, and I have more of my evenings back, and that's really nice. And it's another way that I feel valued for the work that I'm doing isn't on top of the thing that they value, is actually what they value.
And what about the IT support for all these? Because you need additional support apart from the clinician. So it's something that you are managing internally?
Yeah. So we have our own NALHN digital health team. And we have, I don't think all the networks have this, but we have a chief medical information officer. So his name's Jared Marks. He's a computer engineer, I'm going to say, or computer science background. And then he came to medicine much later, like Mel, but probably later than Mel because he's greater and got more beards and stuff like that. And Jared's really interesting. He kind of lives in the digital space. I feel like he talks to me and I don't fully understand everything he tells me. Actually, part of my job, and Sam Gluck, who's here, Sam and I share an office, and he was a bit unwell, so I filled in for him. And he was going to talk about his PhD, so I thought I probably won't talk about Sam's PhD. But part of Sam and my work is helping translate what Jared says in Jared Technology Talk to the rest of us mortals who work in the hospitals. But we have some, again, key people like him who have vision for this digital twin. I would have never even thought of that idea. And he has a team of people that just work for him to advance our local projects forward, as well as the broader digital health team within NALHN that does work across lots of things and builds dashboards and builds other coding stuff to extract data. That kind of stuff's happening. We're all the time, you saw on the video the chief surgical resident, he said, I need a digital solution so I can track which discharge summaries are outstanding, because Sunrise can do that but in a very basic way. I need something that can instantly produce that by ward, by team across the whole hospital. So the digital team said, yeah, we can do that. And 2 weeks later, there was a dashboard that was available to everyone. And so he's like, hey, I've done this. You guys should all share it. Now we're all using that to track our discharge summaries. So it's a great team that can get an idea and produce a solution, tweak it, and then we just use it. And it's just normal, which is cool. It doesn't have to take 12 months to produce these things.
How do you work at trying to spread the expertise and the innovation across all of SAN instead of staying in a single NALHN silo?
That's outside of my role. No, I think ultimately, for all my fun talk about bagging other networks, actually the more I was an intern at QEH, so I felt like I was a QEH doctor. And then I moved across the RAS and registrar and I felt a bit like a Callan doctor. And then I moved to Lyw for 6 months, and went down to Flinders for 6 months, and more I've actually felt like I'm an SA health doctor. With all the jokes aside, it's all just fun banter, to be honest. I think, there's always this kind of friendly competition of things that we do, but ultimately, if something gets, implemented, it's eventually just going to share and it gets spilled over into these other networks. Many things already have. So the stuff that I did on discharge summaries, for example, that became Callan policy in middle of 21. And then the following year, it became NALHN policy, and I'm literally at the moment, one of my things is rewriting the guidelines so it will become NALHN policy. It's already Mount Gambier network policy, it's already Flinders and Upper North policy, and that's something I've gone, this is cool, let's share it. And the same thing with all the coding videos. Every time I produce a coding video, I send it to every executive director of medical services across all the ones who have been interested. So that's about half the rural networks and all of the metro networks, because I'm going, this is a free resource. If it helps us all have more accurate data and more accurate funding, why not? We should all have this. And a lot of people even email me from other states going, is it okay if we use this video? And it's like, it's so polite. It's like, it's on YouTube. I can't stop you. But it's so polite because there's a bit of a culture of making sure they don't want to step on toes or stealing ideas. I'm like, I put it on YouTube because I think it's a good idea, and I haven't monetized or anything like that. Maybe one day we'll get a bit of money back from all my late night editing that I've been doing. But I think ultimately, if you've got a good idea, we could share it, and we should definitely do that with SA Health, where we're all under the same firewall of digital stuff. So once we have good digital ideas, we should share them. And as you spoke to, it's about implementation. And there's other networks willing to adopt new workflows. And even like the stuff that we do, we're trying to improve, like we're trying to change the discharge summary for the whole of EMR. It's a long process, but we're in that process now that will align with a lot of the work that I've done and other people have done as well. And that will kind of just bring everyone on board with a better way to do discharge summaries. So that's a positive thing. And then following that, hopefully the AI will then just write them for us. And there we go. So it's essentially right. Thanks very much.
Just so that people can come and ask their questions.
You can like and subscribe if you want. Don't do it because I asked you to.
And check out Andrew's YouTube channel as well.